You know, it's really a remarkable time in oncology. Our anti-cancer therapies are getting more and more effective, and because of that, our patients are living longer, fuller lives. It's a huge success story. But this success has also pulled back the curtain on a new challenge, managing the long-term and often very subtle toxicities that really impact quality of life. And today, we're going to zero in on one of the most significant yet frequently overlooked of these, male hypogonadism.
Okay, let's just start with a number that should really make us all pause. 100%. In a key study looking at men with non-small cell lung cancer, every single patient treated with the targeted therapy crizotinib developed low testosterone. Let that sink in. This isn't just a minor side effect, it's a near universal consequence for this specific group, and it perfectly illustrates the sheer scale of the endocrine disruption we're up against now.
So, what exactly are we talking about here? Well, male hypogonadism is defined by that biochemical criteria, low serum testosterone, usually somewhere under 300 to 350 nanograms per deciliter, but it has to be coupled with clinical symptoms. And here's the really tricky part for us in the clinic. The key symptoms, things like fatigue, mood changes, muscle wasting, can so easily be mistaken for the cancer itself or just general side effects of treatment.
To really get our arms around this, we've broken this explainer down into 5 key parts. We'll kick things off by framing hypogonadism as a neglected toxicity. Then we'll dive into the impact of modern targeted and immune therapies, and after that, we'll cover the traditional effects of chemo and radiation. From there, we'll pivot to the really complex part, managing the risks and benefits, and we'll wrap up with some actionable guidelines for your clinical practice.
As more of our patients survive their cancer, our clinical focus has to expand. It's just not enough anymore to only prolong life. We have to ensure the quality of that life. And endocrine health is an absolute cornerstone of that. But it often remains this neglected part of survivorship care, kind of overshadowed by the more immediate oncologic concerns.
And believe me, this goes way beyond just managing symptoms like fatigue or low libido. Untreated hypogonadism has really profound systemic consequences. We know it's intrinsically linked to the development of metabolic syndrome, which in turn dramatically cranks up the long-term risk for major cardiovascular events and type 2 diabetes. So the bottom line is, by not addressing hypogonadism, we are potentially setting our survivors up for significant future morbidity and mortality.
Now, this whole issue gets even more complex when you factor in the very therapies that have absolutely revolutionized oncology. Targeted and immune therapies have been a game changer, for sure. But they've also introduced this whole new spectrum of adverse events, and the endocrine system seems to be a prime target.
Just take a look at the tyrosine kinase inhibitors. The prevalence is honestly striking. For patients with metastatic renal cell carcinoma, studies show up to 80% develop hypogonadism on sunitinib and 41% on pazopanib. And as we just saw, for non-small cell lung cancer patients on crizotinib, it's a staggering 100%. These are not outliers. This represents a significant drug-specific risk to the gonadal axis.
Immunotherapies, on the other hand, they present a really unique challenge. It's almost like a 1-2 punch with a dual mechanism of injury. On one hand, immune checkpoint inhibitors can cause a primary hypogonadism through immune-related orchitis. That's a direct inflammatory attack on the testes. But on the other hand, they can cause a secondary hypogonadism through immune-related hypophysitis, where inflammation of the pituitary gland just messes up the entire HPG axis. And if we zoom in on that secondary mechanism, we see that anti-CTLA-4 agents, like ipilimumab, are pretty well known for causing hypophysitis. The data shows this leads to secondary hypogonadism in about 2 to 13% of patients. Now, while that prevalence might seem lower than with some TKIs, it's still a critical immune-related adverse event that directly impacts gonadal function.
Okay, let's shift gears a bit and talk about the more conventional therapies. Now, the gonadotoxic effects of chemo and radiation are, very well documented, especially in survivors of pediatric cancers or testicular cancer, but they are still a primary and ever-present cause of hypogonadism in the broader oncology population.
With chemotherapy, the mechanism is usually just direct cytotoxic damage. It's kind of a brute force approach. Platinum-based agents in particular are notorious for their impact on the testes because they directly damage the Leydig cells that are responsible for testosterone production. So that direct insult leads to primary gonadal failure.
For cranial radiotherapy, the risk is all about the dose. It's a very clear dose-dependent relationship. The pituitary damage follows these predictable thresholds. As you can see, the somatotropic axis is the most sensitive. We see growth hormone deficiency at doses of 18 gray or more.
But for the gonadotropic and corticotrophic axes, you typically see deficiencies in LH, FSH, and ACTH pop up once that dose to the hypothalamic pituitary region gets above 30 gray.
Now here's what's absolutely critical for us as clinicians to remember. This damage is not immediate, it's progressive, and it's insidious. The average time it takes for these deficiencies to show up really tells the story. Growth hormone is often the first to go, around 2.6 years post-treatment. Gonadotropin deficiency follows at almost 4 years, but look at TSH deficiency. It can take over a decade to manifest. This just hammers home the point that long-term, even lifelong surveillance for these patients is an absolute necessity.
So understanding the causes is one thing, but actually managing the condition, that's a whole other ballgame. This brings us right to the central clinical dilemma. How in the world do we treat iatrogenic hypogonadism safely and effectively in our cancer survivors?
And that leads us to the million-dollar question, right? Is testosterone replacement therapy, TRT, even a viable option for these patients? This is where we have to be incredibly meticulous in weighing the very clear benefits for quality of life against the potential and very real oncologic risks.
The evidence really urges us to be cautious. I mean, take the HABITS trial. It was actually stopped early because of a significantly increased risk of recurrence in ER-positive breast cancer survivors on hormone therapy. And in prostate cancer, while the debate is still going on for low-risk disease, TRT is a major concern in high-risk patients. And then, beyond the oncologic risks, you have the systemic stuff, VTE, stroke, and unfavorable lipid changes, especially with oral formulations.
So what this all boils down to is a point that's summarized perfectly in guidelines from ASCO and NCCN. The decision to initiate HRT must be individualized. It has to be guided by a deep understanding of the patient's specific cancer, their hormone receptor status, how bad their symptoms are, and their risk of recurrence. There is simply no one-size-fits-all answer here.
But the good news is, we're not empty-handed. We have this growing arsenal of non-hormonal strategies that really should be our first-line approach, especially in our high-risk patients. For vasomotor symptoms, SSRIs, SNRIs like venlafaxine, or even gabapentin can be quite effective. Urogenital symptoms can often be managed with simple non-hormonal moisturizers and lubricants. And for bone health, we can always rely on bisphosphonates or denosumab to lower that fracture risk.
All right, let's pull all of this together into our final section, a clear framework for decision-making that you can actually use in your practice, based on the consensus from the major oncology societies.
It really boils down to a practical 6-step process. First, you've got to thoroughly assess the primary tumor's biology and that patient's individual risk of recurrence. Second, quantify the symptom burden. How bad is it really? Third, and this is a big one, always trial non-hormonal options first. Fourth, this has to be a shared decision with the patient. Fifth, if you do decide to start TRT, use the lowest effective dose for the shortest possible duration. And finally, sixth, you must implement a rigorous surveillance protocol.
So if you were to summarize the current clinical consensus, it would look something like this. For ER-positive breast cancer survivors, systemic therapy is a hard no. It's contraindicated. For low-risk prostate cancer survivors, you're in a zone of caution. For most other cancers, it's a case-by-case decision. And the big unifying principle across all of these guidelines? Emphasize non-hormonal options first.
So after all of that, what's the single most important message you should take away from this? It's this. We have to shift from being reactive to being proactive. We need to be actively screening for hypogonadism in our at-risk patients, asking the right questions, ordering baseline testosterone levels, and not just waiting until the symptoms become completely debilitating. And that leaves us with one last critical question for all of us to think about in our own practices. Are we truly integrating endocrine survivorship into our routine oncology care? The evidence is overwhelming that these aren't just niche issues. They are absolutely central to the long-term health and quality of life of our patients, and they demand a much more comprehensive, multidisciplinary approach in our clinics.